going to talk about is essentially what you do normally in cardiac ultrasound, right? So this is something with bread and butter. You have done this 100 times. But I just want you to, this is one of my favorites. So it's just a concept which didn't occur to me for practicing cardiac ultrasound for 10 years or whatever. So eventually it takes one bad outcome, right? So to think about something. So anyway, again, my disclosures. It all started with this. Have you ever wondered why the patient coded right after intubation? This hopefully didn't happen to you, but unfortunately it does happen not infrequently, right? So about 60% of critical ill patients do need intubation, and about 25%, even the ones who are successfully intubated, about 25% actually decompensate during the peri-intubation period. So peri-intubation hemodynamic instability is not that uncommon. We would love to have that stabilize those patients so they don't collapse in the peri-intubation period. One of the under-recognized things during the peri-intubation period is RV failure. So either there's increased RV afterload or decreased preload or decreased contractility from a variety of conditions, whether it could be pulmonary embolism or exacerbation of COPD or ARDS, whatever that might be. That's where we run into problems during intubation. So RV being a very thin-walled structure, highly compliant, it only ejects blood against a vascular resistance of 20% compared to that of systemic circulation. So it is more vulnerable compared to LV, especially during intubation. So what exactly happens? So you have a pathology like pulmonary embolism or other things we have discussed, so where there is increased in pulmonary vascular resistance. So RV starts to dilate, and then progressively it leads into RV failure. And then what happens, the IV septum now, it deviates to the left side. The septum is not contributing to the RV contractility anymore. And eventually the filling of the left side goes down, there is decreased cardiac output. This is the problem with RV failure. So point-of-care ultrasound, we've been using it for a long time. So it's a great tool in patients. I'm not advocating to do point-of-care ultrasound in every intubation. The ones who don't look good, they're critically ill, whatever that is, so you don't have a good feel for them. They're on the edge. So they are the ones I think you definitely have to pick up the probe and scan prior to intubation. So what it does is it gives you this non-invasive, great assessment of the airway, RV, right? And it also tells you if there are any signs of RV failure. We'll quickly go through that in the next few slides. And it helps you direct appropriate interventions to stabilize their hemodynamic status while you're intubating the patient. So all of you who have been using point-of-care ultrasound are very familiar with acute RV failure signs. A dilated RV, poorly contracting RV, the free wall is not moving. And there is a D sign where the septum looks like a D and maybe even pushing more towards bowing more towards the LV. And the LV is getting smaller, and there is loss of inspirator collapse in the IVC. Easy to pick up. And again, I have no doubt you have done hundreds of cardiac ultrasounds, and these are the findings you can easily pick up. So here's an unfortunate case where these findings weren't picked up prior to intubation. Big RV in both views there. And prior to intubation, D sign. Post-intubation, look at how much the septum moved, small LV, patient coded, unfortunately patient died. Unfortunately, these things, if they are detected early, before the intubation, you can probably follow some of the strategies to prevent some of these bad outcomes. So essentially, if there is an opportunity to avoid or delay intubation when you find RV failure, that's the best approach. In some cases, that may not be possible. Maybe you want to pick non-invasive NIPV, so that way it doesn't decrease the preload as much as you do the endotracheal intubation. And on the other hand, if you're going to intubate the patient, maybe you'll be more careful with the PEEP or airway pressures in these patients if you already knew that RV failure, the patient has RV failure. And this is one of the things, I have made mistakes, and I have seen people do mistakes consistently, is when the pressures are down, let's give them fluids. And that's the worst thing you could do for RV failure patient. Essentially, you're going to kill the patient if you give fluids to the RV failure patient. What you're going to do is you give fluids, it's going to over-distend the RV, it's going to put more stress on the RV wall, decrease the contractility, and then the septum starts moving to the other side, and then there's decreased contractility, a contribution of the septum to the RV, decreased LV filling, decreased cardiac output. Eventually, some of these patients end up in cardiac arrest. So best thing probably in these patients is pulmonary embolism. We call ICU and ask for INO in patients like this. So if you give inhaled nitric oxide, you can selectively pulmonary vasodilate them. Unless they have severe LV failure, they really do well. It decreases the afterload on the right side, and patients do respond well. The other options you have is vasopressors, epinephrine, norepinephrine. Essentially, they raise your systemic pressure, and then that's a better option than giving fluids in these patients who are touchy hemodynamically prior to intubation. So that can even augment the cardiac output. So to summarize, the things you know, the technique you use, the cardiac ultrasound, just think about that prior to intubation and see if that patient has an RV failure. If you do find the RV failure, be careful prior to intubation. You may want to avoid or delay the intubation or choose some of these things like inhaled nitric oxide or vasopressors instead of giving fluids. I'm going to stop right there. We're so sorry we're going to over a little bit. And again, thank you for coming.